Welcome to the Let's Talk Health Forum. I am Dr. Dan Pavlik Jr., and as always, I am trying to bring information on the world of integrated and alternative medicine and the world of traditional medicine. I myself, as a chiropractor, have worked with many doctors over the years, and I'm always, curious of what everyone does. What is the involvement in the medical world as far as how we can put that patient in the center of the model and make them the most important aspect of what it is that we do. On today's show, I don't have a live studio guest. However, one of my previous guests, Carl Erickson, who is the CEO at Stand Up MRI, he has a doctor that he's interviewing who is a neurosurgeon with Orlando Health, Dr. Verla. They talk about the multi-position MRI and the benefits of what a surgeon will look at from a standpoint of surgeries and how it relates to outcomes. Enjoy.
So of all the specialties that you could have gone into, neurosurgery, what made you choose that path?
So growing up, I had a strong desire for things that I couldn't explain, which was a bit odd, wanting to know more. And it started off with space, right? This desire to become an astronaut.
Really?
Because I felt like things here could be explained because we see it every day and there's some article about it everywhere. But there was this mystery about space. Where is it? How big it is? And how do we get there? And how is life out there? So I wanted to be an aeronautical engineer. So that passion existed for some time up until I discovered how crazy that was. Trying to study space and time when there was more need here. I saw more people suffering here, in need of help here. And that's when, growing up as this teenage boy somewhat shifted my focus to wanting to do more here to help the guy next to me rather than some extraterrestrial environment, which I don't know whether there's anything that's going to help us today.
Yeah.
So that shifted me into medicine. And then within medicine, it was now the quest for what could provide the most benefit and rare and not easily available in some of these developing countries. So orthopedic surgery was something I admired. Just too many bones in the body.
Yeah.
Going to do that. I did like cardiac surgery as well and plastic surgery. But the thing that drew me to neurosurgery was the irreplaceable concept of everything we do, like irreversible, irreplaceable organs. Everywhere else in the body, heart, lungs, liver, you can donate that organ. There are machines that can keep you alive while we go to the next step. Neurosurgery was the only thing where it's a one-way street, right? You make a mistake, someone dies. You make a mistake, someone gets totally paralyzed. You delay treatment, the outcome is irreversible, right? You can't. It's not like. I have ultimate respect for heart surgery, but you can have a very low ejection fraction and you're about to die, and then they pop in a new heart, and you get it's like a car about to run out of gas, right? You fill up the tank and they're back on. But with us, as things progress, sometimes it becomes really irreversible, and that's what kind of sold neurosurgery to me. It's high stakes, but it kind of keeps you grounded, keeps you humble, and keeps you honest, right? Because you can't fool around, right? You have to be honest, you have to be empathetic, and you have to be genuine because everything you do has consequences, right? For example, on Sunday, I was on call, and this patient came in with a massive amount of hemorrhage in the brain from a tumor, which there are multiple ways you can treat that. But it's one of those situations where I look at the patient, they're declining in front of me. Um, if I do nothing, they could be dead within a day. There's family at bedside crying, and the only solution is to take them to surgery and take the tumor out and all the bleeding, which we did. And thankfully, the patient is wide awake, talking, and happy, and it's a desirable outcome.
Yeah.
But if I didn't act there and then, that would be game over for this patient. Family now would have a lost loved one. So that was the thing that took me in, and the rush of trauma, right? It's the unpredictable nature. I don't know what's going to come in, right? I don't know how it's going to come in and what kind of fix we're going to offer.
That's got to be really rewarding, though, for everything that you just said as far as your background, why you became what you are today, and to be able to help that family out. You know, that's you know, that's awesome to be able to do that.
And it's funny because even when I did that, I had a moment of reflection with the family, right? Mm-hmm. And it took me to my background. The family member volunteered in Nicaragua, right? So we started talking about the health system, not here, but there.
In another country.
Where this exact situation would have played out at a funeral, right? Because, we're talking a patient declines at, 9 a.m., shows up in the ER at 10 a.m., surgery's done by 11 a.m., and by 6 p.m., they're fine, right? So this is all happening within 24 hours. But if you go to a country where the diagnostic features are inexistent, then you come in, one, you cannot be diagnosed, and two, there's really no treatment options because no one really knows what's going on. And typically, that's what leads to the ultimate demise, right? And sometimes, even if they can do the CT scan of your head, there's no neurosurgeon available that day. Right? And it becomes a waiting game where every time that you spend waiting, those are, neurons and cells in the brain that are just dying in a way that cannot be replaced. So, that was actually a moment of reflection for me and that family where we were thankful to be here in an environment where we can act, we can save a life, right? You can make a difference. I know it's one patient at a time, but it's very impactful, right, to be able to do that. And as someone with a master's in public health, I don't want to do that to one patient at a time, right? I want to take a step back and look at things from a broader view. How can I cast the web to reach out to as many people as possible? So not just me, but other people are capable of doing this with resources that we can provide. Because sometimes the lack of care is just the lack of resource. We can provide that to some of these communities and even here within the U.S., there are a lot of places that don't have access to good health care.
Absolutely.
Right? So it's not just reaching out to international territory. It's also reaching out in our backyard. And figuring out how do we help the guy next door who can't afford an MRI. So.
Well, I'm glad you didn't go to Mars then. It sounds like there's a whole lot of things.
I'm happy to be here on Earth.
So, brain and spine?
Yes.
Rewarding for you, which one is it?
So,
how is that operating in those spaces?
So I do more spine. I did a fellowship in complex reconstructive spine surgery and also minimally invasive spine surgery. So I do more of that from an elective standpoint. I enjoy the trauma call and the cranial call because that's where most of my brain tumors and intraparenchymal hemorrhage and just all the head bleeds, that's where they come from, right? Not usually from an elective standpoint. But it's tough, it's challenging. We're talking about millimeters away from dangerous territory, right? Just this morning I had to remove a big disc from someone's cervical spine between cervical 5 and 6, right? And again, we're so close to the spinal cord where there's just a thin film.
Mm-hmm.
It's like a saran wrap, right? That's how thin the film is between where I am with an instrument and where the spinal cord is and the patient's ability to walk again. So the space is quite small, right? The accuracy has to be extremely high.
Yeah.
And the margin of error, I mean, again, no one is perfect. You know, there's always risk associated with any surgery, but for us, the margin of error has to be so minimized that to make the surgery worth it,
Yeah.
right? Because if the risk of injury is worse than you just living your life without surgery, then you shouldn't have surgery, right? So we have to be better than average. We have to go above and beyond to make sure that we stay calm when everyone else is panicking, right? Because there's someone's life on the line. Same thing with the traumatic brain injuries that come in. No matter how bad they are, I typically tell all my friends and residents when I was in residency, and even the PAs, remember this: the surgeon has to be the most calm individual in the room, and that is even more true for neurosurgery, right? Because you're legitimately dealing with life or death,
Yeah.
and every step, every decision you make has to be geared towards saving the life in front of you, um, the whole way
Yeah.
from start to finish.
So I'm obviously on the imaging side of it. So, and I'm sure you utilize that as a tool to get you as far as, you know, where your strategy is going to be when you get in
Yeah.
there. I'm sure you probably lean on that pretty heavily, but you know, is there often times where you get in and maybe it's not as what reflected on film or on the images when you get in there, or
Oh yeah.
yeah,
So the body is a very dynamic entity, right? And one of the most challenging aspects of imaging is it's very static, right? Um, that's why we always ask the question: where is your pain? When do you have the pain? What activity generates the pain? And wouldn't it be nice to have some sort of imaging modality that I can say, okay, well, do the thing you do that generates pain, so I can do an image at that time and also at rest, right? When you have no pain. Someone with a mobile spine with instability and one vertebrae moving on the other, there are x-rays that can be done for that, right? With just standing view, bending view, and leaning back. That tells us the extent of movement. So, X-ray, CT, and MRI, those are the three big things that we utilize as far as surgical decision making. Unfortunately, a lot of the X-ray is the only thing that is truly dynamic, that is easily accessible. The CT, unfortunately, it's typically a static sequence that you supine for. MRI, thankfully there are multiple positions that you can have the MRI done. And it's interesting you brought that up because I saw a patient in the emergency room where when he's laying down, he doesn't have any pain. When he stands up and starts walking, he has a foot drop, right? The CT and X-ray were totally unremarkable. The MRI shows a bulging disc, right? But that's a supine MRI.
Yeah.
So it's interesting. I actually told him in the emergency room, I wish we could do your MRI with you standing up.
In that position, right?
Right. Because when you upright, the load on your body is going to create a different physiologic environment that cannot be captured when you're supine.
Yeah.
Right. So there are times when we've gone to surgery from a supine MRI, and the disc is not where we thought it would be. Right. This was an extruded disc fragment that had popped out, and there was just a thin portion holding it onto the major disc space. But the patient mostly had symptoms when they moved around. Right. So it wasn't surprising that the MRI and everything else didn't particularly match up. But again, you go in there, you get lucky sometimes you actually see it, but there are people that have gone in and not seen the disc. I mean, the same is true for because remember, surgery is prone, right, for the lumbar spine. So the same is true for people that get the MRI in the position of pain, right? You could be upright when you get uh, your pain, and the MRI is in that position, but then surgery is in the opposite
Right.
direction.
So it's,
So it's a difficult thing. And do we do surgeries upright? Sometimes we do, but it is challenging, right? But yeah, from a diagnostic standpoint, imaging is critical to what we do. And I tell patients that the X-ray looks at the bone and the alignment. The CAT scan goes into further detail at the bone quality and the bony anatomy. Sometimes it gives you a hint on the soft tissue, but as a neurosurgeon, to really look at the nerves, which nerve is being compressed, which part of your brain is being compressed, we have to take a look with the MRI.
well, so that's interesting. So a lot of times, like somebody will come in, they'll say, they've got pain running down their right leg, and I suppose that you find that matches the MRI, so it just helps your strategy going in. You kind of know what that story is based on where their pain is, right? That's pretty cool.
No, absolutely. So I call it a clinical radiographic correlation, right? It has to match. If it doesn't match, that's when you start doing unnecessary surgeries, and that's when we start doing essentially sham surgeries, right? Because if you have a bulging disc at, say, L4-5, right, and we're expecting it to compress the right L5 nerve root, and then you come to my clinic with radicular pain down the left L3 nerve root, doesn't match, right? That pain could be disabling, could be functionally debilitating, but it doesn't match the MRI. So that is typically when it gives us the chance to pause and figure out what other diagnostic tool is missing to characterize this symptom, right? As opposed to just jump in and fix this big disc, which the patient is not symptomatic from that. So they have to match. And that's the most difficult conversation I have in clinic, when there is a clinical radiographic mismatch. And they're like, but why am I in pain? And sometimes we got to be humble enough to say, I don't know.
Yeah.
I honestly don't know. We can get more tests and do more, other things, but sometimes we just don't have an answer.
So a lot of times these guys are worked up, and I know sometimes they end up in the ER, but say for instance on a traditional patient, they're seeing their family practice office for a period of time, then they might go to pain management. So most of these people are worked up to the point where they've exhausted a lot of these other options as far as more conservative treatments are concerned by the time they end up to you. So do you feel like that, like them being a little bit more teed up for you? But I'm sure if we're having this story that some of those things, the mismatch still shows up like in front of you from time to time.
So the thing is, as the one at the end of the line, no one else really spends time to do that clinical radiographic match, right? Because there's back pain and leg pain. I go into the specifics of the dermatomal distribution. You got to draw a line from your back to your toe. Where exactly is that pain traveling, right? Once you say it's my entire leg, then that's a problem, right? Because I have to know.
Yeah.
And the reason being, every time you do an MRI, there's going to be degenerative changes, right? That's just a fancy term for arthritis of the spine. Right, it doesn't mean much unless it really correlates with why you're here. So even though they've seen their primary care provider, they've seen the chiropractor, and they've gone through physical therapy, I find a lot of times no one has sat them down and showed them the map of their body and showed them the MRI. So more often than not, I'm the first person
to have the dermatome conversation,
to have that and to even show them what's inside. Because they were intrigued when you actually show them. And most of my patients that have been more satisfied than not are the people that actually appreciate what's within. When I can show them, okay, this disc will cause you to have this symptom, which is exactly what you have. So that makes sense why if we go in and remove that bulging disc, this pain will be gone. Now remember, you may have other pain, they're not related to this disc. And the more they understand, the more they're happy with the outcome, even though it's not 100% reduction in symptoms, but at least they understand that match and what needs to come out of that.
So I've heard the term, and it's been in the medical field for a long time, failed back syndrome. Is a lot of that just because of that mismatch, and or is that something else?
It's multifactorial,
Okay.
right? Some patients would just not do well. It's if you think about everything we do in medicine, there's never 100% guarantee of a successful outcome. When you do a lumbar decompression, right? Because the failed back surgery is usually for the lumbar spine.
Right.
It's rarely for anything else. I mean, it's characterized in general, but it's mostly used for the lumbar spine, the thoracolumbar region. When you do just a simple laminectomy, right? Sometimes that's good. Again, it's not 100% guarantee. So even if there's 80% chance of success, the other 20% that don't get better, sometimes they end up requiring additional surgery, right? Even for something very minimal, but because they've already had surgery and they're having persistent symptoms, it makes the likelihood of someone else offering an additional surgery or the patient buying into more surgeries a lot higher up. So that could be, one thing. If you do multi-level laminectomies, and the patient now has loss of the support from the back of the spine and starts falling forward, right, which is commonly referred to as kyphosis, now that could be an issue, right? If you do multi-segment instrumentation, or even just one segment instrumentation, right? Once you lock in a segment of the spine, you accelerated the degeneration above and below, right? That's what we call the adjacent segment breakdown.
Okay.
Because the spine is designed to be mobile at every segment. So if you lock one segment in, you have the one above and below. They go crazy and start trying to figure out, okay, well, what am I supposed to do with this new environment where my neighbor's locked in?
Do you find that to be a little bit more because of the mobility of like the cervical versus the lumbar? Do you find it in the cervical more often, or is it still in the lumbar as well?
I think you see it either way, right? Because now you got to look at some of the features. If you're already starting to have wear and tear at that segment above and below where you're going in, then that could be an issue, right? Or there's any mild listhesis at those levels, that could be an issue. So it's a fair game. I do see quite a bit in the lumbar spine just from the sheer load of the body, right? So, but that's also an issue. And then what's been now big in the literature in spine is just the spinal deformity correction, right? Matching the physiologic alignment. You have the pelvic incidence, the pelvic tilt, the lumbar lordosis. So we're trying to, there have been studies that have come up with what the ideal number is for these parameters and even more. So if you do a, lumbar fusion and you're not trying to put the patient within those parameters, that puts the patient at a very high risk of having postoperative back pain or requiring additional procedures. So that, again, adds to that population of failed back surgery.
Yeah, and I'll say this too, because I think that there's some accountability on the patient side to maybe they're doing physical therapy before to strengthen their core before they go in to surgery, and then making sure that they're also following through with their PT on the back end, right?
Yeah.
I would assume. I mean, you've got one component of it, but there's a pre and a post, right? So, making sure that everything, you've done, stays. And I had lower back surgery a few years ago, so I kind of know that process. So, it's so crazy because I've actually changed my workout routine to be less heavyweight, but a lot more core strength.
Yeah.
And it's crazy. I stopped going to the gym because they're like, what is that dude doing bear crawls for? But, things like that where your core's just strengthening. But I think that there's some patient engagement as well with the success of everything that you're doing, I would imagine.
Yeah. I mean, the most difficult part of a poor outcome is who to blame.
Yeah, right.
Right. And, I always say if a patient goes through the trouble of near death, because that's what surgery is, right? If they go through the trouble of near death and have you operate on them, then they are motivated to keep pushing the envelope,
Mm-hmm.
right? And I think as providers, sometimes we just say, oh, that was a poor patient selection, or the patient is not pushing. And sometimes I try to pause for a second and say, well, wait a minute. Let's just assume that the patient is doing everything 100% correct. What are we missing,
Yeah.
right? What else can we do? Not everyone we know is going to have the perfect outcome from surgery. But then that other 10%, which could be where this patient is, what else can we provide,
Mm-hmm.
right? And that's kind of where a lot of things, where there's more physical therapy, or trying to figure out what more can be done from a surgical standpoint, or just neuromodulation, right? Which is becoming big. It's
Mm-hmm.
not, especially with filled back surgery. Maybe the solution is not more surgery.
Yeah.
To make it more pain,
Yeah.
right? Maybe the solution is to just reroute the signals that go to the brain, because what is pain?
Yeah.
Pain is not a reality; it's a perception of stimulus,
Sure.
right? So that's why I can grab a pen and poke you and anyone else, right? Poke myself, and we're all gonna react to pain different,
Mm-hmm.
right? You can get an IV and it hurts you way more than it hurts the next guy, but it's the exact same stimulus. So that perception is what neuromodulation strives to do. Let's just reroute the signal to the brain. Instead of feeling pain, we're gonna dampen that signal, so it's the same stimulus that comes in from the bulging disc or from the filled back surgery doesn't hurt as
Yeah.
much as it currently does without any surgery being done. So
Yeah, that's awesome. Yeah, I think when we had first come out with the stand up, our the thing that we were promoting to the doctor's office was better outcomes for you guys, because we were able to, like you had said earlier, identify what's truly going on in a position of pain for most patients. So imaging upright, we had actually had some pretty kooky marketing material where we had somebody in there in the position of a golf stroke, right? We ditched that pretty quick, but I mean, it was like,
Yeah.
hey, it hurts when I go back. I'm like,
Yeah.
okay, well, but it was pretty cool. And to your point, I think that we were just doing our best to just say, hey, there's more going on. And like I had said earlier in our conversation, it was hard to go to a neurosurgeon right off the bat with the technology, just because it was you're younger and a little bit more, we had talked about some of the technology that's available. When I came out 20 years ago, I was talking to the old guard, and these guys that were just stuck in their ways, like, this is the only way you can image somebody. And so it was kind of cool to see some of the story go from some of the primary care offices to get into guys like yourself. They were a little bit more open-minded, and so it's a pleasure meeting you today. But yeah, it's awesome.
Yeah, but I mean, if you really think about it, right? Like, we're striving to have more imaging in the position of pain and also position of surgery, right?
Sure.
Because I do a lot of spinal cord tumors as well, and some of them in the lumbar spine. I do want to see because every time when it's supine, you always have this false illusion that it's coming from the ventral aspect of
Sure.
the spine, as opposed to the dorsal aspect. So a supine versus prone, right, versus sitting up. That's going to give us three different data as far as this floating thing within the spine. Is it tethered to one side or the other? But yeah, I mean, there's a whole lot more that you can get from just the dynamic view. And it's interesting that the whole idea of dynamic imaging. I first thought about that watching ESPN. They had this vest where it had all the pressure sensors and all that.
Oh, and okay, yeah.
Yeah, so they don't do that show anymore, but they'll give it to the athletes. And one example would be they'll give it to an NFL player, and they'll take off full speed and then do a huge jump, right? And the whole goal was to analyze all the muscles that are contracting during that jump. But that was as dynamic as you could get, because you could see the pressure distribution throughout the body, right? As you take off,
Mm-hmm.
go up in the air, and what they do. Because one of the question was, even when they hit peak height, why does one guy land here and then the other guy land 6 feet away? Right. Again, it depends on how you propel yourself midair. But how do you propel yourself midair as a human being? Right. So it's all these questions that they were asking. And it's the same thing that we have in neurosurgery, right? There's so many things that we wonder. Like, okay, well, like with the MRI of the brain, and when we do some of these posterior fossa surgeries, surgeries in the base of the skull with kids, they have the dynamic CSF flow MRIs where you can see the flow of spinal fluid and kind of understand, is it truly obstructed,
Mm-hmm.
or is it flowing at a lower rate? And even when we go in and do all these procedures to open it up, right, you can do a post-procedure MRI to figure out, is the flow rate better, right? So it really helps us to see what's going on in real time.
Yeah, that's really cool. So are you referring to, like, say, a Chiari malformation?
Yes.
Okay.
So that's one of them, and
Yeah.
then just any obstructive mass in the base of the head. So
Oh man, that's awesome.
yeah.
So we had talked about, you had mentioned like traumatic brain injuries.
Yeah.
Is that so? In our 3Ts, we started doing some of these traumatic brain DTI
Yeah.
scans. So we're able to do a base routine brain, and then we're able to do some post processing and really kind of show what's going on inside the brain. I don't know if where you're at has any of that info, but
Yeah, we do.
provide that to you.
Yeah, I think for traumatic brain injury, they somewhat get triaged in a different paradigm. The MRI is mostly for a prognostic utilization.
So you're
right?
saying more clinical. It's a little bit more clinical.
Yeah, so it's mostly they come in. There's a huge amount of blood in the head,
Got it.
and we got to take them straight to surgery, get it out, or admit them in ICU, put a monitor in their brain to check the pressure. If it's high, they may or may not require surgery, right? Typically, when we get an MRI, it's usually when the clinical progress is not what we expected. It's a bit delayed,
Got it.
right? 25-year-old comes in with traumatic brain injury. We're expecting them to be better by day 4, and they're not. That's typically when we try getting an MRI to figure out, are there areas of strokes from the injury, any areas of more injury that you cannot see on a CAT scan.
Mm-hmm.
So that's where the MRI becomes very handy. Now, a lot of the functional mapping, right? That's typically when we have the planned surgeries, right? Because that gives you enough time. It's not ER to OR in like 2 minutes. There's no MRI in between. This is usually the outpatient that has a big brain tumor next to an eloquent area, right? You want to look at the white matter tract. You want to look at language. You want to look at all these things. So you get the functional MRI done to see pretty much all the tracts. That's actually quite cool.
Yeah.
Because you can see where everything is running, and actually in the OR, right? There are filters you can apply to some of the technologies we have in the OR where you can actually see the depth of where you are and the 3D concept, or not model of the actual brain you're operating with, and it somewhat gets projected and superimposed on what you're doing. So if there's a deep white matter tract next to where you're resecting the tumor, you can actually see that.
Wow, that's
And of course we do intraoperative monitoring, because remember, if you have a big mass pushing on the brain, the functional MRI you get is with the mass. The moment you start taking out a small portion of that, the brain starts to shift back, so your accuracy gets compromised, which is why the actual intraoperative monitoring becomes critical.
That makes sense.
Yeah, because you may think, oh yeah, this big 8-centimeter mass, the eloquent area is 10 centimeters deep. But when you resect 4 centimeters of that mass, everything shifts, right? So now the eloquent area is 6 centimeters deep, not 10. So, and that's the concept that I think if you rely on one thing versus the other, like personally, there's the functional imaging, there's the intraoperative neural monitoring that checks, signals from the brain down to your arms and legs and also back.
Yeah.
And you can do, language mapping as well in the OR. The ultrasound is the true, dynamic view of what's going on because it shows you right there. You can see the confines between the brain and a brain tumor. And as you're taking it out, you can see the border and the margins. So the more intraoperative adjunct you use to kind of guide you, the better the outcome. But it's never one versus the other.
How do you, I would imagine, some of the surgeries that you're doing are more complicated and you've got to stay focused for, I don't know how long, maybe I know maybe the spine doesn't take that long, but maybe somebody's brain, you might be in there for hours, right? I mean, how do you stay focused that long? I mean, it's kind of like, I watch NASCAR and I'm just sitting there going, dude, these guys are driving down the road and they've got to stay focused that whole time.
I think being focused in the OR is how you stay focused outside of the OR, right? A lot of people say, oh yeah, surgeons have different personalities at work and at home. You have to have the same personality, right? If you're not calm outside of the OR, it's going to be very difficult to stay calm in the OR, right? Because it's a combination of your personality, your ability to function under stress, and your ability to push yourself to the limit, but at the same time not compromising the patient's care, right? I mean, I've been stuck in the OR for 15-hour cases, right? And you just keep going. Like, the case keeps you interesting. And that interest never dies. And one of the things that made me realize it was neurosurgery and nothing else was the fact that anything in neurosurgery wakes me up. And that's it. Like, I was like, well, I'm sold.
That's your thing.
Right? It wakes me up no matter what.
So have you ever gotten in there and it's, I hate to say this, this is new. I've never seen this. I mean, do you consult with another colleague of yours,
It happens. There are times when you look at, say, oh, okay, well, never seen that before. And it goes back to the concept of humility, right? You have to be humble enough to accept that you don't know, and humble enough to get help, right? And I've asked for help with things that I don't know. And if I'm anticipating there's going to be something that I'm not used to, I talk to the people around me. I'm fortunate to be in a group of 11 other neurosurgeons, right? So
chances are they've seen.
Chances are they've seen, right? Just a couple of days ago, I had to sit down with one of my colleagues to review a patient's scan, because it was a little bit confusing to me what the pathology, this goes again back to the clinical radiographic mismatch, right? I couldn't understand what was going on, and I had exhausted all my personal resources. So I'm like, just phone a friend. Grab a friend in the hallway and see what they think. But that happens. It happens to the best of us.
Yeah.
You go in there and you're like, okay, well, that's new. Didn't see that coming, and just have to ask for help.
That's awesome. And I know we had talked about school, but I think that that's a really important thing in hearing that story. So, Steve could probably edit me, but I thought that was really cool that, you had gone to school, left school, became a civilian for a couple years, and then ended up in Duke.
I'm still a civilian, by the way.
Yeah, well, you know what I mean. I'm going to say this, and the thing that's so impressive is I worked out this morning before I came here, and you just went and helped somebody, get their life back. That to me is like, I feel, a little less right now.
They're all important. Yeah, so, I came here, started school, and it was actually a complete shock to my entire existence, right? Because I was born and raised in Cameroon. That's all I knew. Never left the country until I left for the U.S. And it was very challenging because no one could understand me. I couldn't understand anyone, right? Everyone spoke so fast, and it was difficult. Science was great because math is math. It doesn't matter what language you speak. I could just read the board and figure out what you're saying. But a couple weeks in, I got the tuition bill. I was like, okay, well, that's not gonna happen, right? And it's one of those where, again, another moment of realization, right?
Mhm.
It doesn't matter how smart you were from the country you came from. Reality is always gonna hit, and when that hit me, the decision was just take a step back and refocus, right? Because if I had proceeded with school, I would have essentially bankrupted my entire family, right? Because the amount of tuition at that time was more than my entire family's net worth, right? So
Yeah.
it didn't make sense from a financial standpoint to do that. So I just took a step back and just refocused, right? Just worked, saved every penny I could, and when the time was right, I went back to school, right? And it's the same thing. Even when I went back to school, it was just a question of focusing, keep aiming and striving for something better. And it's funny, a few of my family members are actually in medicine. So when I decided to go back to school, it's like, well, yeah, you can apply to whatever you want. These are some of the easy things to get into. So I probably sent in about 6 or 7 applications and pulled them back until I decided to just chase my passion. I see things from an engineering standpoint, and I joked about it when I was growing up, but that's just the way I see things, and that's what actually led me into spine. Because in undergrad at Duke University, I worked at a spine biomechanics lab, and it's because understanding how things are made and repaired, how the body stands when it's functional, and what it is when it's not, and what we do in between to fix that. That's what got me all intrigued. And I really don't see any other part of the body where biomechanics plays a better role than spine
That's
surgery.
fine,
So
absolutely,
that's what just soaked me, man,
yeah,
through
that
and
makes
through.
sense. That makes sense. That's awesome, man.
Yeah.
Yeah, like I said, I worked out this morning. I just-
I could have worked out this morning if I
I-
didn't have a case.
Yeah, yeah.
Yeah, I
When,
try to.
when you have cases, I mean, how many are you doing back to back, or are you, I'm not quite sure
Yeah.
like how OR time works for you guys. You got a case, and
So I mean, the goal is typically, it depends on the block time. So I
Mhm.
operate, it's an average of 3 days a week, plus minus weekends if an emergency comes in.
Mhm.
But some of the busy days, they typically run till about 7 or 9,
Mhm.
right? Like yesterday, for example, I was operating till about I think we're done at 7 p.m.
Wow.
Again, it's 3 big cases that just fill up your whole day. And then today I had a case at 7 a.m. And then tomorrow it's probably going to be another long day into the evening. I mean, again, some of the elective cases I schedule them. I try to not do more than 3 a day.
Yeah.
But sometimes when you're on call and emergencies come in,
Yeah.
they have to get done. If I can't fit them into my calendar, I ask one of my partners if they can just take over.
Yeah.
Because ultimately the patient has to get the care, right?